All right, so we're going to be talking about hematology today. So this is the second part of my internal medicine EOR review, and maybe one of the most feared topics could be hematology. There's some like oncology stuff on here also, but honestly, we're just going to dive right into it. So we're going to start with the first thing here, which is clotting factor disorders. And we learned about that right around here. Number two. Oh, it's the worst. Okay. I guess we could just I could probably just go through some of this. So, intrinsic pathway versus extrinsic pathway. When we talk about this, you want to put heparin on the left, warfarin on the right, and you do your intrinsic and you do your extrinsic. So I literally just thought about this, but you could say hi, HI is heparin and intrinsic, and then you could say we for warfarin. So we, hi, warfarin, extrinsic, heparin, and intrinsic. And then you kind of have to know, well, what clotting factors are on either side. And this is the whole pathway here. You have intrinsic on the left, extrinsic on the right. This is going to spell tenant. So you start with 12, which I believe is the highest that exists. And you kind of just count down. So, and it's going to go in order. So 12, 11, you skip 10 and you go right to 9, and then you continue to 8, and then you bring 10 back in. 10 is going to be where both sides join each other. It's going to be here 10, 10A. Factor 10A inhibitors, that's going to be like your Eliquis, your rivaroxaban, things like that. So you think about, well, why are we targeting 10A? Well, it's because it's going to nuke the entire, both pathways. So if you want to thin your blood, inhibiting this it's definitely going to do it. Okay. And then on the extrinsic side, not as much. It's really all about 7. On the left is more about like subendothelial damage and stuff. Over here is more like trauma. It's not too terribly important. Tissue factor is over here on the extrinsic side. But really, factor 7 is kind of the big one that is over here, and that leads to 10. Factor 7 kind of activates 9. So if the extrinsic pathway is started, it's going to kick this off too. Not sure how important that is. And then everything comes together into the common pathway. So 10, which is stabilized by 5. And yeah, there's this nice little mnemonic of like the V of the Roman numeral fits into the X of the Roman numeral for 10. So 5 stabilizes 10. And then you just kind of count down here. You have prothrombin, which is 2, which then goes into thrombin. So, pro is always going to be the precursor. Then that goes into fibrinogen, which is factor 1, which then goes into 1A, which is fibrin. So factor 1A is fibrin. That is our kind of final piece of all of this. That's what's actually doing the clotting in your body. When fibrin is degraded, that's what a D-dimer is. And 13 at the very end is going to stabilize 1. So I guess 12 isn't the greatest. 13 is. So the highest one stabilizes the first one. Okay. The other thing too here, that's always asked about is what does vitamin K I guess inhibit, right? Vitamin K is going to reverse warfarin. So vitamin K thickens your blood, like spinach, leafy greens thicken your blood. So it's 2, 7, 9, and 10, and then S and C, which actually stop clots. So vitamin K is involved in all of those. I think we go over that. So know that 2, 7, 9, 10 are vitamin K dependent factors. So if you give someone a vitamin K inhibitor like warfarin, it's going to shut all of those off. So 2, 7, 9, and 10. And then protein S and C, which are anticoagulants, again, S and C stop clotting, are going to be involved with vitamin K as well. All of this stuff, I don't know how, I don't really care about that. Yeah, this is the D-dimer stuff I was talking about. This is that fibrin mesh, and then it's torn apart D-dimer because there's two little parts here of these like D subunits. I always thought that was pretty interesting. This is pretty important too. So when you think about somebody with DVTs or a pulmonary embolism, these are your go-tos. And then AFib as well. If somebody has AFib, they have a risk of, a clot in the left, most likely the left atrium, which falls into the left ventricle, which then is shot up into the aorta, which can then go up into like the carotids and then up into like your ACA, MCA, the circle of Willis, right? And cause a stroke. So that's arterial, but like the clot's already there. So that doesn't make a lot of sense. But when you're talking about DVTs, when you're talking about PEs, yes, this is all the stuff you're going to talk about in the hospital. Are they anticoagulated? Are you going to do your heparin bridge to warfarin? I've seen a lot of people on heparin drips, people who are just in the hospital for whatever, get sub-Q heparin because, they're bedbound, they're in the hospital, they're not moving a lot, so they are a blood clot risk. And then, there's a lot of stuff with like pricing and stuff with like Eliquis, Xarelto. Then there's like low molecular weight heparins like Lovenox, and there's like unfractionated, fractionated, all that stuff. This is a factor 2A, which is pretty interesting. So if we thought about where 10 is, 2 is a little bit below that. That's what this Pradaxa is going to be. But that's all like for venous, to stop venous clots. On the arterial side, when you talk about somebody who, has coronary artery disease, well, they're going to be on aspirin or they're going to be on Plavix, which is similar to aspirin. These aren't technically blood thinners, but when you're talking about somebody who is coming in for a trauma, treat them like blood thinners. These are definitely, pertinent things you want to mention. But aspirin and Plavix are going to work more on, these are going to manage work on platelets, and these are going to work on the coagulation side. Whatever, more pathway stuff. All right, now we get into coagulation disorders. So the first two that you really talk about are just a general thrombocytopenia. And what does that mean? Well, it means, clotting cells low, right? Thrombocytosis would be a high amount. So this is just, somebody with low platelets. You can suspect a host of different things. Bone marrow failure, that's where platelets are created. Yeah. Right. Isn't the spleen involved in there too? Yeah, bone marrow. Something with the spleen in there. I don't know, man. Okay. So yeah, meds can do this. NSAIDs, I don't really care about that too much. ITP, however, which has like multiple names. So idiopathic thrombocytopenic purpura, also immune thrombocytopenic purpura, whatever. I think it's purpura. So this is more of an autoantibody thing. And you always think about this when you think about treatment for something and you see a steroid like dexamethasone. Yeah, is that stopping inflammation? But why is it stopping inflammation? Because it's preventing your immune system. So it's an immunosuppressant. And then you talk about, well, heavier things. You talk about like IVIG. You're actually giving somebody like immunoglobulins, immune factors, because their immune system is messed up. Autoantibodies, it's attacking. So you're giving them kind of a clean immune system, clean immunoglobulins. So that's something I never really connected as like a first year student. I was just memorizing this stuff and never really thinking about, Yeah, this is like an autoimmune issue. Um, so you're going to give them immunosuppressants, and you learn a lot that about a lot more of those things like methotrexate. You know, it also took me a while to realize why do these medications end in AB? Because AB is antibody. You're giving somebody, clean, non-broken antibodies. So you'll see that a lot more with like rheumatoid arthritis and lupus and things. But anyway, so ITP here. So idiopathic means we don't know what caused this. It just kind of happens. It's an autoimmune reaction to attacking these whatever GP2B. But what can cause this? What can create this? So a lot of viral stuff, CMV, chickenpox, HIV, lupus, antiphospholipid syndrome, which we'll talk about as well. So you're going to see the disruption of primary hemostasis. So what is primary hemostasis? That's your platelets. So this is more like superficial stuff. So secondary hemostasis would be more like joint bleeds and muscle bleeds, deeper things. And we'll talk about that when we talk about hemophilia. But this is just like platelets. So it's bleeding gums, it's purpura, which are going to be like, here's like your petechiae. Petechiae? Yeah. I promise I'm slightly intelligent. I promise I know how to read. There's just so many words sometimes. Anyway, so yeah, so look for that stuff, your purpura, your petechiae. The main goal of treatment here is just to get to a safe platelet count, so not necessarily normal. They can go as low as 30K until you're actually like concerned, especially if they're asymptomatic. So less than 30K, you're going to be at risk for like spontaneous bleeds. Less than 20, close enough. But yeah, so first line treatment, which can cause remission, is just simply dexamethasone, Decadron. It's a steroid, right? You can use IVIG, but this surprisingly, you think IVIG is more powerful. You're giving them IV immunoglobulin. This is going to cause remission, but it's not actually. So this is actually just reserved for patients with active bleeds. This is like a short acting thing. Steroids, they're on this for a little bit longer. So that's going to cause remission. Second line treatment is, here's spleen stuff. So splenectomy. Yeah, but why? I'm like, am I dumb? Am I dumb? Am I dumb? So it removes the primary site of platelet clearance and autoantibody production. So yeah, so the spleen is part of the immune system. Why can't I think of the name of that body system? The lymphatic system. Okay, so the spleen makes autoantibodies. Don't know if I knew that, if I'm being honest. Okay. So take it out. This is second line treatment, or you bring in the big guns, you bring in the more like synthetic antibodies. In this case, it's going to be rituximab. And this stuff isn't important. Thrombopoiesis stimulating agents. It's going to create platelets. That's not really important. Okay. Now we get into this class of things called microangiopathic hemolytic anemias. So these are a subset of hemolytic anemia. Here we see damaged small vessel endothelium. So we get platelet aggregation, fibrin deposition, and then shearing forces, which damage red blood cells, which is why you see these schistocytes or like helmet cells. So these are literally, they're not bite cells, but they're sheared forces. So they're like red blood cells that have been like cut, I think. Yeah, fragmented red blood cells, damaged red blood cells. That's a pretty good picture. Fragmented schistocytes. Bite cell is G6PD, right? Yeah, G6PD is bite cell. Okay. So really for this, I put this into a chart. HELP syndrome really doesn't come up. Just know that this stands for, you see this more in like preeclampsia, but it's hemolysis, you know, elevated liver enzymes and low platelets. Just like know that triad. All right. So HUS versus TTP is important. So what are these? So this entire thing, these are MAHA. These are microangiopathic hemolytic anemias. All right, so HUS, which is hemolytic uremic syndrome, you're going to see this in kids. You have to know that HUS is the vignette is always going to be a kid, primarily like somebody under 5. It's actually the most common cause of kidney injury in children. And this is all GI related. So you're actually going to have somebody who, is having diarrhea. So they're going to have, E. coli from some type of contamination, milk, beef, but they're going to have the bad version of E. coli, which is called STEC, which is Shiga toxin producing E. coli. So a particularly nasty breed of this. The toxin is going to go to their kidneys and it's going to cause, kidney injury. So you're going to have gastroenteritis, and this can go into renal failure. Like this is an emergency. This is a big deal. You're going to have bloody diarrhea, but no fever. And then there is a triad here. So this is going to be just, hey, anemia. That's why we're talking about this. But you're also going to have thrombocytopenias. You're going to have low platelets, and then you're going to have renal failure. So it's definitely a big part of this. All of this stuff is normal. So the clotting cascade is not being affected. This is all primary coagulation. This is like a platelet issue. So nothing in the extrinsic or intrinsic clotting cascade are affected at all. Now, HUS can progress to something called TTP. I guess in the case that you get this HUS with an adult, this can go to TTP, which is like extremely life-threatening. These are both pretty big deals. So in that case, if you think you're not sure which one, you actually start plasma exchange. And this, I guess, is similar to IVIG. When you talk about things like Guillain-Barré, like another autoimmune process, both plasmapheresis and IVIG are like treatment options here. You see this more with like MS and stuff. So kind of the same thing, but instead of like putting in just IVIG, you're taking out plasma. I think you're like filtering it and then you're putting it back in. And plasma, from what I remember, is like where all your immune factors are and stuff. When did we even start talking about plasma? Oh, geez. Yes, yeah, exactly. So plasma, which is 55% of your blood, 90% are water, but 10% of that is going to be where you have hormones, antibodies, coagulation factors. So that makes sense. So if this is a like an autoimmune issue, which it is it? I guess the Shiga toxin is like it's so the path here is actually the toxin is causing apoptosis, which is like programmed cell death. It's actually it's not destroying platelets. This actually is not autoimmune. This is toxic. It's using up your platelets to form in all these small blood vessels. So you have this microangiopathic, damage. Your platelets are being used up, which is why they're low. So again, we're using plasma exchange in the case it's TTP. So we'll talk about that in a second. Dialysis, again, we're talking about that kidney failure. I've never really heard of this before. Atypical diarrhea negative, but you can get this from like quinine. Quinine, which is like an anti-malarial, causes like so many different problems. But I think the big stuff here is, know the triad, know that, look for like milk or beef in your vignette, look for diarrhea, specifically bloody diarrhea, no fever. And then, if this is an adult, I don't know if you would do this if it was a kid, but if it's like, hey, what should you treat? And plasma exchange is an answer, I would go with that. Okay. So then we go to TTP. So not ITP. This is not idiopathic. This is thrombotic. So this is driven by activity of something called ADAM TS13. So what does ADAM TS13 do? It cleaves down von Willebrand factor. So what is von Willebrand factor? The way I think about von Willebrand factor is it is like Velcro in your blood vessels. It is Velcro in your blood vessels that when there's some type of like endothelial damage, or really damage anywhere where you're using this, the primary uh, clotting pathway, platelets are going to stick to it. So if you don't have von Willebrand factor, platelets have nothing to really stick to, and they can't all pile on top of each other. So what ADAM TS13 does is that it cleaves down von Willebrand factor. In other words, when the clotting is complete, ADAM TS13 is the cleanup crew. He comes in and says, yeah, we've stopped the bleeding. You're fine. Let's get all these platelets out of here. Let's strip off this Velcro. That's exactly what it's going to do. However, in TTP, ADAM TS13, our cleanup crew, maybe think of Adam as like a janitor, is not around. So von Willebrand factor is stuck to the blood vessel or the site of the bleed or whatever. The platelets are stuck there, and platelets are going to keep piling on. What happens, just like with HUS, when platelets are being used up, we get thrombocytopenia. So again, the platelets aren't being destroyed. They're just being used up, which means our platelet count is going down. So that is the pathophysiology behind this. You could see right here, we get these platelet-rich clots. So this can be an autoimmune issue. So it could just be you have an antibody against ADAM TS13. Yeah, so look at this. Most common is actually idiopathic. So even though we were just comparing TTP to ITP, which is idiopathic, this can still be most common idiopathic. I never noticed that until just now. But, and why HUS and TTP are linked is that Shiga producing E. coli, oh geez, is also an option here, or is also a cause. Now this has a pentad. It carries over the triad. So what are we talking about? We're talking about microangiopathic hemolytic anemia with those schistocytes, thrombocytopenia, which we now just learned why, acute renal failure because there's toxins, whatever. And then, but neurologic is where we start to ramp up. So the terrible pentad, the two that we're adding on. So we're going to have you get neurologic issues, which what does that mean? Really anything. You get a straight up TIA, focal deficit. So I guess like just a stroke, mental status changes. Why would you get a TIA or focal deficits from a stroke? Well, because your blood keeps clotting. You can't take off von Willebrand factor. You have all these platelets. I also didn't connect that until just now. And then fever, I don't know. I'm not really sure why, but you get a fever. So what are your labs going to look like? Again, we're not affecting anything. Sharing the right screen? Yeah. We're not affecting anything in the intrinsic, in that like secondary pathway, none of the clotting factors. So all of this stuff is normal. ADAM TS13 is going to be low, but it takes like 7 days to get that back. I mean, that's pretty specific lab you're going to be pulling. First line treatment is plasma exchange / plasma pheresis. And like, what is that? What is plasmapheresis? Obviously, it's taking plasma out and putting it back in. Just like giving you better plasma. I mean, which has actually plasma doesn't have platelets. Platelets are over here. So I don't really know why. I mean, we did talk about like, there's this acquired antibody. You know what I mean? That's the interesting thing. Like the underlying cause is E. coli. Why are we not treating with like antibiotics? Like, yeah, you want to treat like the platelet issue as well. So why don't we just give them platelets? So that's, I think, where this, but again, plasma infusion, fresh frozen plasma, there's no platelets in that. Like, according to this, I don't know. I mean, you don't want to get too far into the weeds here. But again, because there's autoimmune-ish things happening, you can do steroids, You can do, antibodies, rituximab. I've never heard of this. Or you can do fresh frozen plasma here as well. Okay. DIC, the big buzzword here in terms of like a pants question is always going to be that this patient starts oozing from any site, from if they have an IV in or like a central line or something, or like a finger stick from like like a point of care glucose. You're going to get oozing. Always a word to look out for. And this one is weird. So disseminated intravascular coagulation. This comes up in a couple other places. This comes up in hypothermia. It's a pin drop diagnosis because it's so deadly. Number one cause is going to be sepsis. This does involve all the clotting factors. So definitely look for it's going to prolong all of this stuff. And the interesting thing is here is like you clot so much, it's called a coagulation. You clot so much, it's kind of similar with like you use up all your platelets and then you might bleed. You use up all of your clotting factors that then you start bleeding because you don't have any clotting factors left. Treatment, a blood transfusion because you're going to be bleeding. Treat the underlying condition if they have sepsis. And you can give them fresh frozen plasma cryoprecipitate. So I think the big thing for this is, can you identify this on a vignette? It's really not that complicated. But knowing like the pathophysiology and then knowing the labs here are going to be important. Any coag factors are low because you're clotting so much. S and C are doing their thing. So they're being used up as well. So clotting factors and anticoagulation factors are going to be low. Heparin-induced thrombocytopenia. This is like you give somebody, I think, too much heparin. There's also like a warfarin thing. It's like a warfarin-induced something. I don't even remember where that came up. What's like the big stuff here? I think just like dragging and dropping, knowing that, hey, what is a serotonin release assay used for? It's HIT. What is a 4TS probability test used for? HIT. You want to stop heparin, you want to avoid warfarin in that acute period, but you want to use argatroban. That's pretty like buzzwordy. Formation of HIT, antibody complex, serotonin. Yeah, knowing just like serotonin is involved here. Whatever. That's some weird stuff. All right. I think I'll take a break before we get into the low bleeding disorders. These three, I mean, these two, like very testable stuff. You see this all the time on like Cram the Pants. So we'll try to talk about, I think I went over some of this with the ER. So maybe we'll go into a little bit more detail with that in a second. All right. So in terms of the bleeding disorders, all right. So von Willebrand disease, hemophilia, and vitamin K deficiency. So von Willebrand disease and hemophilia, these are going to have to do with like factor 8. And if we remember, that is on the heparin intrinsic side, which is why they're going to cause a prolonged PTT. Vitamin K is going to be with, warfarin is a vitamin K inhibitor. So that's going to have to do with PGINR. Von Willebrand disease, chromosome 12. I don't know that that's very super high yield. What I think is important, though, is that it's the most common inherited bleeding disorder, not hemophilia, von Willebrand disease. And remember, we talked about what von Willebrand factor is. It's that Velcro that platelets are going to stick to. So if we don't have that, then platelets can't stick and we're going to bleed, right? So you can either have this from a deficiency itself or some type of dysfunction. We'll see there's different versions. Von Willebrand factor actually also protects factor 8. So there's a bunch of different types to this. Okay. So type 1 is the most common, easy enough to remember. It is genetic. So this is autosomal dominant, and it's just a quantitative von Willebrand factor reduction. So not only are there not as many, but activity as well. So you have some von Willebrand factor, but they're kind of lazy. So that's number one. Treatment here is just going to be actually desmopressin, which is um, also vasopressin, which is also DDAVP, which is also ADH, antidiuretic hormone. These are all the same thing. And why does desmopressin help with a bleeding disorder? I remember looking this up before, I think in my ER video. It just does. It just does. Okay. So that's the treatment. You can also give somebody von Willebrand factor concentrate. Okay. Before we get into the madness that is 2, let's go into 3. 3 is more of a rare one. So as the opposite of autosomal dominant, this is going to be autosomal recessive. And this is going to be von Willebrand factor is either absent or severely reduced. Okay. The treatment for this, we're not going to use desmopressin. For desmopressin, I guess like you need some von Willebrand factor for this to like work. This you have either none at all or almost none. So you have to give them not only von Willebrand factor, but you have to give them their factor 5s, their factor 8 back as well, because those are going to work together. Okay. When we talk about type 2, you have von Willebrand factor, but it's just broken. It's not functional. Okay. 3 times out of 4, we're going to use desmopressin here. 2B, and I always think 2B or not to be, this is the one that is just a little bit weird. It's the only one you're going to use just von Willebrand factor concentrate for. And it's also the other one that has this like ristocetin-induced platelet aggregation. So if there's a question, it's like, what is the, what's increased RIPA? Then it's going to be 2B. 2N mimics hemophilia, but I think just knowing like 1 versus 3 and knowing that RIPA has to do with 2B or not to be should be like good enough. Is there anything else crazy here? Why is this not scrolling? So with hemophilia, this is male only. So predominantly. So it's going to be a male in the vignette. You have to know hemophilia A is a factor 8 deficiency. To go to hemophilia B, just add on one more. And that's going to be factor 9 deficiency, also known as Christmas disease. You always want to look, because remember we were talking about platelets and like more superficial bleeds. This is going to be hemarthrosis, muscular bleeds. Look for like a kid running around the playground. There's always like, bleeding inside of his knee and has like, ecchymosis and stuff. Treatment here also is going to be desmopressin. So that's good to know. I actually totally forgot about that. Avoid aspirin NSAIDs, avoid non-contact sports. Vitamin K deficiency, I feel like we don't really talk about very much. Just give them vitamin K. This PICA2 thing, PIVKA2 thing is here. So whatever. There's von Willebrand, clotting disorders, factor 5 Leiden, you want to know, has to do with miscarriages. All of these are going to be actually factor 5 Leiden, prothrombin. This has like never come up ever. It's like prothrombin mutation. Never seen that on like a smarty pants question or something. But factor 5 Leiden, remember, factor 5 is going to be what stabilizes factor 10 once we get into that common pathway. This is like an inactivation of what cleaves this. So factor 5 Leiden is around more, so we clot. This is a clotting disorder, which is why the treatment is our blood thinners. For 3 to 6 months, not lifelong, no. And kind of the same thing for this prothrombin mutation. If you remember, prothrombin is down here. Actually comes right after that factor 5 and factor 10. Now, protein CS deficiency and an antithrombin 3 deficiency, I feel like protein CNS comes up a lot more. Treatment here is lifelong. It's actually heparin and Coumadin. That's pretty crazy. Or the direct oral anticoagulants. Oh, this is where you get that warfarin skin-induced necrosis. So if you have protein CNS deficiency, then you have an increased risk for that. And just in general, warfarin-induced skin necrosis, it's a rare complication of warfarin and starts within the first days of treatment, associated with a large initial loading dose. So look out for that. Antiphospholipid syndrome, this again, just know this is like associated with pregnancy, morbidity, and mortality. This comes up in lupus. You'll see that in rheumatology. So you have some like antibodies and stuff. Treatment again here is heparin and warfarin. So factor V Leiden antiphospholipid syndrome have to do with like pregnancy complications, miscarriages, and then know that antiphospholipid syndrome is associated with lupus. Acute anemia. Yeah, there's like all this stuff, anaphylactic, or I mean, this isn't really on this list. I'm not going to go crazy with that. All right. Do we want to do more? Not really. There's obviously a lot more to do with this, but I feel like that's enough to kind of scratch the surface in terms of like clotting disorders and things. So I think we'll call it there. We'll get into more of the meat and potatoes, different types of anemia and things in another video.